Hello everyone, and I'm thrilled to launch this third edition of our Cath Lab Complication course. I warmly welcome everyone in this room and all those joining us online. Who wants to be a doctor must learn from four teachers: a book, a tutor, a patient, and he himself. But we all know that the ultimate teacher is the patient that suffers the complication under our care, especially when he comes back to the follow-up and confronts our mistakes. So why are we doing this course? Because we are believers. We believe that making mistakes is human, and even the most experienced hands may encounter complications in complex cases that we all are doing. We believe that everyone that had done a complication has felt failure and guilt. But we know that failure is not, but the complication is not a failure actually. It's an opportunity to learn. We also believe that most of us who ever had a complication want to share their experience to learn so the colleagues may avoid them in their practices. And we also believe that this friendly and open atmosphere is the best place to share, to reflect, and to grow. And at this point, I would like to pass the microphone to my friend, Sar Mincha. He's a friend and colleague, and together we faced a lot of very painful complications. Very many painful complications. And together we work to push this course forward. So again, I welcome everyone. I hope you will enjoy this meeting, and the floor is yours.
Brilliant. All right, thank you. So again, thank you all for coming. It's a great pleasure to have you here at Shamir. For the sake of time, I'll try and be brief. This is the main agenda for today. We have basically two sessions. So the first session has 5 cases. All cases are presented by top-tier operators, and hopefully you will enjoy them. We have distinguished panelists that will direct the conversation. We have Professor Amit Segev and Artur Kerner, and they will, I will assist them, but they will do the first session. And then we have another session, again moderated by Elad Asher and Lior Perl. So hopefully we'll have a really, really nice time learning together. We're also being broadcast online for most of our colleagues around the world through ADN. Now, this session is going to be unique since we're going to use interactive discussion with you. So just pull up your phones, scan this. You'll have the opportunity to scan this later. But basically, every case will have a pivot, will have a junction in which a decision will have to be made by you. Okay, so we will assist the operators in making the decisions. This will also drive the discussion forward. So every case has a pivot which will help us learn together and learn through the dilemmas of the operator. There's also a WhatsApp group in which you, especially here online and on site, will be able to communicate and use it as a chat room. Okay, so if you have questions, those of you online, have any questions? We're looking at the chat, so if you have any ideas, questions that you wish to push, we will try and push that through the moderators. So again, the QR code, that's the first one, the WhatsApp group, and finally, we want to thank all the support that we have from industry. I mean, this could not have happened without your support. So all the companies here are really welcomed here, and we wish to thank you for all your efforts and support throughout this course. And with that, without any further ado, I would like to call Professor Segev and Dr. Kerner, and we will start our journey with our first presenter, Ishai Sccci, right? One last housekeeping for those who are here. In order to get out and not pay for parking, for those of you online, you can also try it, but I'm not sure it's applicable. You just, when you go out of the gate, you just say Kenes Tinturim, and you wink, and then you can go out.
Sounds promising. Okay, honored to be the first presenter. My name is Ishai. I come from the Tel Aviv Sourasky Medical Center. and I'm gonna present you Primed to Save. So we'll start with the case presentation. We have a 70-year-old female. She has a history of diabetes, hypertension. She's after a right carotid endarterectomy. She's a heavy smoker. I did not write it, but she also has peripheral arterial disease. And she was admitted to the internal medicine ward with basically an NSTEMI, a clinical picture of unstable angina during the last couple of weeks with a minimal troponin rise. And this was her initial ECG with a sinus rhythm, slight ST elevations in AVR, maybe V1, and ST depressions, 2, 3, AVF, V5, V6. And we took her to the cath lab, maybe a day or two after she was admitted. That's the first angiography of the RCA that shows an occluded mid-RCA with a critical stenosis in the ostium. And that's the left system. Maybe you can start appreciating the slow flow by the end of the injection. And there was a pressure drop when the catheter engaged the left main. This was another angle. This was the second injection. And as we inject, the patient tells us the most terrifying thing a patient can say: I am going to die. And then she dies. And this is the very short description of chest compressions. So we have a diagnostic catheter inside. The patient is in PEA cardiac arrest. And the technician starts the BLS. And this is where we are. And I want to present you the dilemma of then what. So we start CPR. We call the code blue team. So they're on their way to intubate the patient. And then what we do. First option is to focus on excellent ACLS, achieve ROSC, and then do the left main PCI that she needs. Second option is to place a Lucas, switch to a guiding catheter, and then do the left main PCI while we chest compress the patient. Third option would be to place a femoral impella CP during CPR and then do the left main PCI, or do an ECMO CPR and then do the left main PCI.
All right. You have the microphone. Let's just vote and can you show us the menti? For those of you who did not have the option to scan it, all right, that's the opportunity to scan and answer. Do it with your phones. Oh, okay. So again, you can scan it. Let's wait for a few seconds.
So, can we see the... Okay, so it's a discussion part, right?
Yeah.
You want me to start the discussion?
Maybe
show
show
us
the results again.
The menti.
The Menti results.
Yes.
So most of you favored placing Lucas, switching to a guiding catheter, not connecting the patient to mechanical support, and continuing by left main PCI during chest compression and CPR. The second option was ECMO CPR and then left main PCI, and only the minority focused on excellent ACLS and waiting for a miracle of ROSC. So this is left main catheter induced dissection, and the patient is unstable. She lost circulation. So what did you think was the best option to regain circulation or to get some conditions to make this complex PCI when you know that there is a false lumen which is larger than the true one, and you will have to engage it while doing CPR?
So I know what we opted,
And let's discuss.
but I think maybe
I voted for like the majority. So I think first we are in a hospital. Things have to be done in parallel. It's not that you do first thing and then another things. You need to put a Lucas, or you just need to continue PCR. It's the same if you do excellent PCR. The only thing that we have several teams. The operator has to focus on revascularization of the left main. He has to be disconnected from the CPR. So you can call another colleague, the resident from intensive care. He should handle the CPR, and you have to focus on revascularization. The only thing that will save this patient is revascularization as soon as possible. You can put Impella, you can put ECMO. This is not like an automatic pilot. You have to revascularize the patient. It's the only thing that so you have to. You cannot spend time on ECMO or Impella. Sometimes it takes time, but so you will focus on revascularization. That should be done immediately during CPR, and you have to ask the team to stop CPR for several seconds in order to continue your intervention. And in parallel, you call, depending on your hospital, you call the cardiac surgeon to put ECMO. You do it yourself, I know, in your place, or you work on the other groin to put the Impella. This should be in parallel, but the main thing should focus on revascularization of this left main. Otherwise, you can put the patient on ECMO for a day, two, he will not survive.
I will challenge your strategy because we have to estimate what are the chances of getting into this left main to the true lumen while doing CPR. And I think these chances are quite low. The patient came to this situation while she was still metabolically stable. And there is another option, not going to revascularization first, but first stabilizing her metabolic state. And if we are doing cannulation for ECMO while calling the ECMO team, connecting the ECMO first, maintaining her in CPR in a good condition, of good metabolic condition, then you have a better chance in a stable condition to do this left main stenting. I think it will be extremely difficult doing it, and I don't have any experience of putting Impella during CPR, and I think it will not be enough while CPR to maintain the patient not in deep shock. So I would favor the ECMO CPR, connect the patient to ECMO, to hear the sound of ECMO on, and then engaging into the left main stenting.
But why not to do it in parallel?
Because because when you do it in parallel, you don't do the cannulation for the ECMO. I mean, I would continue CPR, cannulate for ECMO, cannula for vein, 2 arteries, inserting the cannulas, it's stabilizing the patient, oxygenating her. The complex will shrink. I assume that the complex became widened. And then to do the PCI.
Do you want to push it
audience?
forward?
I can recall several cases in the past, even before the era of ECMO, that we saved such patients just by immediate PCI without any MCS. You put a wire in the true lumen, you just balloon the left main, and the patient recovers. You have normal blood pressure, recovers, and then you can focus on complete revascularization. So I think, again, revascularization first, but now it's your stage.
And there is another.
Even with CPR, you can do it with CPR.
I would ask
trust you, you can
myself,
do it.
what's the rate of survival? Not the fact that patients survived, obviously, but what's the rate of survival when you do PCI during CPR, which is, of course, challenging. So we had a discussion, and we opted for ECMO CPR and then revascularize. So this is already on ECMO. This is the venous cannula. I must say that we initiated an ECMO CPR program around 2 years ago in our hospital. So right now we have a primed ECMO machine in the cath lab, 24 hours, 24/7. And we are able, once we decide to go on ECMO, to initiate ECMO flow within 10 minutes or so. This is where we stand today. And while we start the cannulation, the perfusionists arrive. The ECMO machine is already there. So it's quite quick. So this is what we did in this case. We first put her on ECMO, and then we changed for the guiding catheter, and you can see the flow obviously gets much better even with the left main lesion. We stented the left main. Nothing special here, and this was the final result. Once she was on ECMO, even before we did the PCI, she regained basically heart function, and then we did the PCI, and she actually completely recovered her heart function. She started with a lactate of maybe 9 that gradually went down. Since she was 70 years old and had peripheral arterial disease, we decided to decannulate her on the table after an hour or two, and took her to the CICU just with the mechanical ventilation. She was extubated the next day and went home 4 days later. And we brought her back 2 months later for a second look, and this is how it looked. So that's her case, and I must say that during the last year and a half or so, we had 10 different cases of eCPR that started on the table, meaning the patient came in to the cath lab stable and deteriorated on the table to cardiac arrest, either from left main disease or VF storm, or in one case a PE that we did in ARI. And in 9 out of these 10 cases, the patients went home on 2 legs. So when I consider the rate of survival, I think that being able to stabilize the patient very quick has very promising results. So we believe, at least in our center, with our experience during the last couple of years, that first we should stabilize the patient and then revascularize them. And we always prepare the groin in any procedure in the cath lab, because you never know. When we go for a high-risk procedure with a high-risk patient, we usually prepare the groin even with an access in advance, with a 4 French access in the vein and the artery. I think the price is not very high, and when you're not sure about the patient's condition, it gives you a lot of confidence. eCPR is a life-saving technique in the cath lab, and primed ECMO machine and the well-trained team that undergoes simulations are key for success. Thank you very much.
One technical point. I saw that you used an XB catheter. This is a mistake, I think. If you have an ostial left main dissection, you cannot use
Judkins
an
left.
XB.
Yeah.
Always use the Judkins left. You have to work from a distance. This is the only chance to cannulate the true lumen.
Thank you.
מה זה?
Akash Jain. Yep. So it's a pleasure to have a guest from abroad. So it's a pleasure for us to have Akash Jain joining us. And he will present Navigating the Storm, TAVI Embolization, and Aortic Regurgitation. Benny, are we ready for Akash?
Okay. Hello, good morning. Am I audible? Hello, am I audible?
We can hear you. Please continue.
Okay, good. Okay, so good morning. My name is Akash Jain. I am a fellow from University Hospital Valladolid, Spain. So the patient is a 47-year-old female who is a reformed smoker with no other risk factor. She presented to us with chronic heart failure in NYHA class 3 to 4 on optimal medical treatment. So in the previous history, she had a STEMI in 2021, and we found a left main occlusion, and she was revascularized with Impella support, and the ejection fraction at that time was 30%. The next year, she came again with heart failure, but this time we found that there was severe aortic regurgitation. So we wanted to look for the cause. We got a blood culture, which was positive for enterococcus. The abdominal CT showed embolic infarcts in spleen and liver, but PET CT was normal. So at this point, our hypothesis for this severe aortic regurgitation was either the use of previous Impella or infective endocarditis. Yes. The next year, she was implanted with a ICD for primary prevention. Also, she was positive for Behçet's disease and had Epler syndrome, for which she was on anticoagulation with vitamin K antagonist. And also she had history of severe obstructive sleep apnea, for which she was on CPAP. The ECG showed sinus rhythm with normal PR interval and QRS was narrow. Right heart catheterization showed a higher PCP, pulmonary artery pressure mean was 50, and the resistance was also high, 4.5. So if we look at the echo, we can see there is severe aortic regurgitation, with the EF of around 30%, and also there was moderate mitral regurgitation. So in another view, also we can see the severely depressed LV function along with severe aortic regurgitation. So given this background of a young lady in her 40s with severe aortic regurgitation, with the EF of around 30%, with increased right heart pressures, what would be the preferred treatment option that you would offer? Surgical replacement, TAVI, heart transplant, or medical management?
So, majority of participants voted for TAVI for severe AI. We don't have
It's funny because we don't see,
47 years old.
but you know,
We don't have
we
any
voted
information.
TAVI,
Yes.
we voted TAVI without seeing the CT angio,
Right.
right?
So can you, I think she's 47. We did not exclude completely infection. She has severe eye. We don't know whether there is calcium on the annulus we don't know the dimensions of the annulus. We
We
don't
don't
have,
know
Okay.
what is the coronary artery disease burden.
right. And
Okay, okay.
so can you elaborate
uh,
about her surgical risk and about the anatomical suitability
Okay.
for TAVI?
Okay, so here's the CT, and we can see there was absolutely no calcium in the annulus. And the dimensions, the annulus average diameter was around 25, and the LVOT diameter was around 28. And LVOT was way bigger than the annulus. The coronaries were adequate, and the femoral axis was fairly adequate. As far as the coronary burden, previously, as I told, in 2021, she had MI, for which we did left main plasty. And as of now, her angio was normal. The stent was patent, and there was no significant coronary burden.
So what did you estimate her surgical risk, and what did you think about implanting in a 47-year-old patient a biological prosthesis? What was the thoughts of favoring TAVI in this case?
Okay, so and when we had this patient, we presented this to the heart team, and the Euro score 2 was around 2.5. But the surgeons, because the ejection fraction was 30%, and that also with aortic regurgitation. So the actual EF would be even lower. So the surgeons were a bit skeptical about the high surgical risk. One option we had was to consider for heart transplant, because given such high right-sided pressures and such low EF, and it was a global dysfunction. But the reason we offered this patient TAVI was that since she is a 47-year-old female, we wanted to delay the transplant surgery as much as possible. So TAVI was a way to offer, to gain some time before the transplant.
So let's see the procedure.
Okay, so once we decided for the TAVI, then the important question was regarding the device selection. So we had three options here: the dedicated air device, the balloon expandable, and the self-expandable. But at the moment, we had only balloon and self-expandable available with us. Undoubtedly, if the dedicated air device is available, that has the best outcomes, and that should be selected. But for us, we had to select between the balloon and self. And if we look at the previous studies, the Pantheon registry, balloon expandable has somewhat better results compared to the self-expandable. So we went ahead with the balloon expandable. In the balloon expandable, we went ahead with MyValve octocore because the intermediate sizing gives us more flexibility with the sizing of the valve. So in aortic regurgitation, we usually oversize the valve with 20 to 30%, particularly in this case when the LVOT is way bigger than the annulus. So here we have to make sure that we are oversizing at least 20 to 30%. So with that value, we decided to go ahead with a 27.5 valve. So this was a root angio. We can see the aortic regurgitation and the coronaries were of adequate height. So we went ahead with a 27.5 valve. So you can see that this was the initial slow inflation so that we can position the valve. But as we were inflating the valve, you can see the valve literally getting sucked into the LV. So after the final deployment, this was the result. So the valve actually migrated into the left ventricle, and still there was a severe aortic regurgitation, and it was a very low deployment. So the immediate step we did was we took the same balloon, added 2 cc's, and we post-dilated the valve at that place only. So after this post-dilation, this is the result we have. It is still a very low deployment with, I'm so sorry. This was still a very low deployment with a severe aortic regurgitation. So at this point of time, with such a scenario, what would be your next step?
Please walked. So most of the responders, again, are in favor of TAV in TAV. We heard about the surgical risk and about the decision of the heart team regarding TAVI. So, Amit, what do you think are the main challenges in performing TAV in TAV in this case? How do you prevent...
I think first now you are committed. First, my valve of choice to begin with would be a self-expanding one and not a balloon expanding one to begin with. If you have no calcification, I think it's mandatory to use the Evolute. Usually the Evolute. I saw several cases using the Sapien 3 valve, and the technique is to deploy the valve and then immediately push the balloon inside and flare it. So you flare the valve inside the LVOT, and this is the only thing that may prevent migration upwards. I don't know if you use this technique. But now you're inside the procedure, you have persistent severe AI, and you're committed, so you have to put another valve.
So how do you prevent deepening the previous valve while coming from the
First, it's a risk, but you can snare it and, anchor it, and with one snare, it could be enough. But it's a risk, so I would call the surgeon to be standby.
Okay, let's see what you did.
Okay, so as you said, since we are committed, so we went ahead with the second valve implantation. This time we chose the 29 mm valve. So this gave us an oversizing of 34.8%. But this time, unfortunately, when you see, there was a loss of capture. And the valve, actually, we are not able to position the valve properly. And it got migrated to the aortic side, and finally it came off the balloon. So we'll see this film again. There was a loss of capture leading to the migration of the valve to the aortic side. And finally, when we were trying to push it back into the annulus, the valve came out of the balloon and it finally embolized into the aorta.
Dr. Akash, I assume you don't know the reaction of the audience here, but it is wow.
And we had to deploy it into the descending aorta. So
you deployed it in the descending aorta with the valve. It will remain open because of the flow. This is not a problem if the sizing is okay. So how did you continue from here on?
Okay, so then we took another 29 mm valve, and this time we added 3 cc extra, which gave us an oversizing of more than 40%. And this time we tried to position the valve well into the annulus, and initial slow deflation positioning, and the final implantation was, you can see the final result after the implantation. There was absolutely no aortic regurgitation. The coronaries were permeable, and we were happy at least with the third valve. The femoral was closed with one prostyle and one angioceal. So this was the echo post procedure. We can see that there is absolutely no aortic regurgitation. The ejection fraction is very low, around 20%, and which was expected after the valve replacement. So this is another view. We can see that absolutely there is no aortic regurgitation. There was no significant gradient across the aortic wall. And the in-hospital hospitalization was uneventful. The patient had a new onset left bundle branch block. And at 2 months, the patient is currently symptomatically better in NYHA class 2 dyspnea. And the ECG shows normal PR with a left bundle branch block with a QRS of 160 milliseconds. Now again, the patient is planned to be presented in the heart team, and we have 2 options, whether to offer her a resynchronization therapy so that we can still improve her symptoms, or otherwise it is the heart transplant. And also, I think if we consider for the heart transplant, we might have to put a non-covered stent into the descending aorta, because the tip of the ECMO sheath might be interacting with the valve which we had deployed in the descending aorta. So by and large, in aortic regurgitation, because of the large stroke volume and the suction effect, it becomes very difficult to position the valve and make the deployment very precise. There is no official recommendation, but 20 to 30% of oversizing is used in the aortic regurgitation patients. In one of the studies with my valve, the valve embolization was 3.5%, particularly in the tapered LVOT, like in our case, where the LVOT is way bigger than the annulus. And it is associated with increased mortality despite adequate technical resolution. Thank you.
Brilliant. What was her ejection fraction after the implantation?
I'm sorry, I didn't get the question.
The question was, what was the ejection fraction post-procedure?
It was around 20%.
And if you were to take one learning point from the actual implantation, what would you do differently? Because at the end of the day, for this course, we would like to come up with something that is applicable for the next case. So let's say that you're in this case, you know the valve was chosen. How would you treat that differently?
Okay, the first thing would be to go with a dedicated air valve, if possible. The second thing, if in such a case, it is a very non-complication because of the suction effect that the valve might embolize. And so we should be very careful with the wire. It should definitely be in the apex so that we get the proper positioning. And second thing I would be concerned about is the size. We should oversize at least, because the LVOT is way bigger, we should consider LVOT for the sizing rather than the annulus in such a case. So we should not be shy of oversizing maybe 30% or 40%.
I think this case elaborates that sometimes the second valve, the first valve is just a docking for a second valve to stabilize it, and the forces are always toward the ventricle. Another tip for marking the sinuses is to put two pigtails or two catheters, one in the non-coronary cusp and one in the left coronary cusp. So you know all the time during the pacing the exact positioning without even injecting. You have to mark it with two pigtails, and then you have a very good mark. Thank you very much. It was brilliant.
Great. Thank you for this case. Great.
Thank you.
Asa Kessler, קבלו בברכה. Please, welcome from Hadassah, the density of a coronary ring.
The destiny of a
Destiny,
coronary ring.
oh, I didn't sleep this
okay.
night. Destiny, okay. For coronary.
Yeah, well, thank you very much. Good morning, everybody. My name is Asa. I'm a third-year fellow at Hadassah Medical Center in Jerusalem. First, I'd like to thank the organizers for allowing me to present our case. I'll be presenting a relatively rare complication of a diagnostic coronary ring dislodged during PCI. So our patient is a 60-year-old male, active smoker with known hypertension and family history of coronary artery disease. He presented on a Thursday evening to Terem, an emergency clinic in Jerusalem, after 2 hours of epigastric pain. His presenting ECG shows, among other things, anterior ST changes suggestive of proximal LAD disease, and he was brought directly to our cath lab. As the culprit was presumed to be the LAD, we planned for right diagnostic and left guiding with a 6th French diagnostic Judkins right. We used in order to demonstrate the RCA, and you can see the RCA is totally occluded. But that's not the surprising finding. Some of you can see on the left picture, video, and on the right, much clearer, the radiopaque tip of the catheter disconnected and found its way to the left system. It might be easily seen right now, but during the procedure, it was relatively hard to find. And the reason we noticed it during the procedure is that the tip folded during engagement to the right and made it absent, and the absent ring was noticeable. On the right, for reference, you can see two identical catheters with one missing its ring. under fluoroscopy and in a regular picture. Okay, so as suspected, the proximal LAD was severely diseased. This is the EBU guide. The ring was well seated in the first marginal with good TIMI flow. We decided to proceed with PCI to the LAD and think about the ring later. Wire was advanced, balloon was inflated, and 3.5 millimeter stent was deployed with a satisfactory result for the LAD, but this is just the starting point of our case. So the clinical dilemma would be, what should we do with a dislodged coronary ring? I remind you, it's midnight on a Thursday evening or Thursday night. In Israel, that means a lot. We have good antegrade flow to the artery. The patient has no chest pain or discomfort. And the ring is sitting perfectly right. Will retrieving the ring jeopardizes only uninvolved coronary territory? Do we have to take it out? And if so, how and when? So these are the questions. What would you do? Would you retrieve it immediately, maybe in the morning, maybe on Sunday morning? If so, would you anticoagulate? Maybe the perfectly fitting ring found its place. Or perhaps surgical retrieval is the only option. I think now is the time.
For those of you online and on site, you can still rescan and vote, and we will deliver prizes sponsored by Tzamal, Medtronic, and other companies.
Not so happy. I mean, maybe I am. Yes, I am happy. You'll be happier. Okay, so there are several percutaneous options for retrieval. Small balloon technique, 2-wire or more technique, a snare, etc. You probably know it better than I do. Before I tell you what we did, maybe someone would like to share their thoughts. Don't make it look that easy.
You know, the instinct is to retrieve it right away because you don't want thrombosis now in the non-culprit artery during acute MI.
Yeah.
Another option, if it's late at night, you can anticoagulate, to put the patient on heparin overnight and do it the day after. I think it's a reasonable solution as well. So it's an individualized decision at night of the operator, but you cannot leave it there. I think this is 100%.
Yeah.
So we don't know what happens. We don't know what happens if we leave it there, because now the patient is anticoagulated, and when you stop the anticoagulation, this is a nidus for thrombus. There is another option to push it distally to decrease the size of MI. This is also an option that is not written here. But the challenge of retrieving the ring with the same size catheter is challenging. So even if you retrieve it, you need to increase the size of the catheter in order to get it inside, no matter what technique you use. And we have to consider the risks of such a procedure, because it's a violent procedure to retrieve it. I'm curious, what is the option that you've chose?
So we decided to wait. After a team discussion, we decided to wait, as we felt this kind of adventure might not be the right thing during the night. As I said, the patient's stable after an anterior MI. He had no pain, no ECG changes. Maybe trying to retrieve this ring could jeopardize the only uninvolved territory, which might not be as good for the patient. So we waited, anticoagulated him, as you said. On Friday morning, the patient is still stable, no chest pain, no ECG changes. Now it's already challenging. Maybe we should wait till Sunday morning. Unfortunately, which we decided to. Unfortunately, the patient didn't like that idea. And on Saturday morning, he started having chest pain, sweating, and lateral SG changes. So he was rolled back directly to the cath lab. So knowing what we're facing, as you said here, we prepared two accesses, radial and femoral. And we used the femoral access with the 8 French destination, 45 centimeters. And what we saw was that what previously was open is now totally blocked. We used the 7.5 French Sccci sheetless catheter with a BMW, and the BMW successfully crossed the ring. See it crossing, hopefully. Yep, here it is. So the way the ring was sitting in the artery made it easier to advance a small balloon, a 2-millimeter balloon, through it. The balloon was inflated tightly in the ring, as you can see. And after inflating the balloon roughly 2/3 in and fitting it on the ring, the whole guiding system was pulled back. It'll take some time, a few seconds. You could see in the middle picture, you might see the hemostatic valve of the destination. You see the ring is stuck there. So only by opening the hemostatic valve was the ring finally out. Okay, that may be a technical aspect for what exactly to use. Okay, so now once the ring was out, it was time for damage control. So we waited a little bit, a few minutes, and it was administered nitroglycerin, but it seemed the ring had damaged the marginal, and an inevitable stent was deployed, a 2.75 Synergy stent. Now we're happy, hopefully. So what can we learn from this? First, anything can break. Guide wires, OCT markers, stents, guide liners, catheter and microcatheter tips. Second, radial pack ring dislodgement is not so common. I said it's rare, but maybe it's not so rare. My search found only 3 reported cases, although I know there are more. I understand last year another case was presented here with something, a ring dislodged and found itself as the MCA. Yeah, right. That was interesting. I hope they won the case, the lawsuit. In 2 cases, the retrieval was completed percutaneously. As you see here, small balloons, but in 1 case, surgical bailout was needed after failed percutaneous attempt with several wire technique. Okay, so I think in retrospect, especially in light of technical ease, retrieval should have been done early. If not during the index procedure, then at least in the morning. That's something I think we learned. I think thrombogenicity of the device is something we have to take into account because it's not a stent and it's not a wire or anything like that. It's very important to understand that optical technical support and preparation especially is key. And we have to take into account the possibility of surgical bailout. Okay, so our patient was discharged 3 days after, and he was in good condition. This is echo. Echo sometimes is important. Thank you very much.
The case that was presented last year with embolization to the brain, it was in a center where they reuse catheters.
Right, yeah, I saw
I
that.
assume that in Hadassah you don't reuse catheters.
Not yet.
So, Asa, I have a technical questions, and maybe you can, Ilya, do we have a microphone for the audience? So first, not only online, but also people here can join and ask questions, but I have a different question. Let's assume, though, I think you were lucky to deliver a balloon through this little ring,
Yeah.
and be able to pull it backwards, you are very, very lucky. Let's say that from the get-go you decided to do it through a 6 French sheath or 6 French guide, and let's assume that you weren't able to pull it backwards. What would you do? What would you do differently?
First of all, the reason we used the larger bore French was we were trying to telescope everything out with preserving the access.
Right.
That was the main decision. That was the reason we opened up another radial
Access.
artery, just to have another option.
Yep.
A good question. It's not a stent. You can't
So,
really.
so maybe let's ask the audience. Assume that we have this ring, and we push a 2. What was it? 2-0? A
Yeah.
2-0 balloon. So you push a 2-0 balloon, and you pull the balloon backwards, and it doesn't go. It just stays there. So what are the options to tackle this? It just stays there. It's
Ken.
too distal. Any ideas?
What about stenting?
Just put a stent and just secure its spot. That's a good option. That's a fair option. Other options? It's stented there. Okay.
I remember a complication that we have not snared properly. After treating a couple of times, I've put another wire to treat a twist between the wires and bring back to the twisted.
Right. So you pass another wire, hopefully that will tangle the ring and pull it backwards.
Yeah.
One risky business when you're doing that is when you go up to the catheter, it might dislodge and go to the brain. So then you kick up the
Hopefully you
thing.
pull it back into the larger guide.
So if you'll stay all the way to the end, there's another dislodged device. I'm not saying which cases, mine, but basically there's a way that you can pass the device with a larger balloon and pull it backwards. So if you inflate inside the ring and it doesn't go, you distally, and then you also secure the option of dislodging.
Embolization.
Yeah, exactly. Okay.
Last year, it's exactly how they pulled the
Yeah,
ring from the
the
brain.
rings, yeah.
They inflated the balloon distal to the ring and pulled everything.
Yeah, although it embolized to the femoral after that.
Yeah, this is fine.
Thank you.
Brilliant. Thank you so much. So I think we have Haitam Sholi. So Haitam was supposed to be here, but he was kind enough. He had some medical issues with his daughter. So we send our love and hope for a good health. And Haitam, are you here with us online?
Yes, hello everybody. I apologize really not to be.
Everything is
inside
okay at home?
Okay, it's going well. Yeah, thank you.
We keep our finger crossed, man.
Thank you.
All right, you're mostly welcome, and we were waiting for your case.
Thank you very much. So I will talk today about a 47 years old patient with a past medical history of hypertension, hyperlipidemia, and is a smoker with a non-coronary artery disease, the anterior wall ST elevation, and the single vessel disease, the disc deployment to proximal LED, and primary PCI. He was admitted to our department, to cardiology department, with the non-ST elevation MI. And at admission, the patient was stable, as you can see here, and the echocardiography showed a preserved LV systolic function with hypokinesis of anterior wall that is known from the previous event. And he was scheduled to coronary angiography the day next. And here's in caudal view, you can see here's the stent in proximal LED, and proximal to stent, it starts as ISR, I think, and proximal to stent, we can see a stenotic lesion. Here's in cranial view, you can see the stenotic lesion and prox ostial LED. Here's the RCA of the patient, and then a discussion was made, and we decided to proceed to PCI and not to send the patient to CABG, to CBG. As you can see here, there is a stenotic lesion in the proximal LED, as I have mentioned before. We thought it's a calcified lesion, and we decided to replace the sheath, the radial sheath from 6 French to 7 French sheath, and our guiding catheter was EBU 3.57 French. I joined the procedure at this level. Okay, at this point, the patient became relatively hemodynamically unstable and suffered from chest pain with ECG changes. And this was the first injection after catheter engagement. What do you see here?
Is there a running loop of the flow? Can we see the flow or only a still picture?
You will try and see the images.
Okay.
Just show that for 2 seconds and then we'll vote, because I know that's the main dilemma here. Show this again. Okay. You can vote and we'll show that in a second.
So most of the participants thought it was a dissection, a catheter-induced dissection, and the second highest vote was for thrombus.
Okay.
Yeah.
So at this point, the operator that started the procedure told that the catheter engagement, through catheter engagement, the catheter was deeply engaged into circumflex. And our first diagnosis was that there is a dissection in the left main towards the ramus, LCX, and the LED. And as you can see here, the flow is still preserved in LED, but there is no flow in circ and ramus, and the ACT was 340 seconds. So, what do you think? Do you think that we need to go to mechanical
support? Before we go to
solution,
let's discuss a little bit about the mechanism. What do you think? How does it look to you?
A question. Why did you use a 7 French guide? What was the thought? Why didn't you stay with a regular 6 French guide? Why 7?
Because we thought that it's near the osteum, and we may go with a stent from left main into LED in order to cover the lesion, and doing a bifurcation of left main, we prefer to do it with the 7 French catheter. We started it as a provisional approach. We plan to do it in provisional approach. And if we needed a bailout of 2-stent technique, I think it's more easy to do that with 7 French catheter.
So the initial strategy was to stent left main into LED, not only
Yes.
the prox LED, because we thought that there is a room to stent just the proximal LED, but okay.
So there's a differential diagnosis between a dissection and catheter thrombosis, which are both, it doesn't typical to any of them because the dissection doesn't start from the left main, and thrombosis is less likely because of the ACT of 340. But still, to me, it looks more like a thrombosembolization with 2 wires rather than dissection that starts because of the cannulation to the left circumflex.
What I can tell you here.
Was there difficulty to cross the wire to the circ?
I just showed you. I have showed you the running fluoro with wires, yeah, because it was the first the only only fluoro that was saved. The first fluoro that was saved. Okay, we have not saved the fluoro with the. It was the same appearance, but without wires. Okay, but the operator told me two things. The first, that there was a deep engagement of the catheter into the left circumflex, and the second, that it was simple to cross to cross to LED with wire and to circumflex with wire. So you have two wires, one towards LED, one in LED and one in circumflex. After this happened, not before. Okay, so this happened before we have wire in the coronaries.
So was there a difficulty to cross with the wire to the circumflex?
It was relatively simple to cross with wire. And it's something against dissection, yeah, as a diagnosis.
And Haitam, what was the patient's status at this point from hemodynamic standpoint?
This was the blood pressure of the patient when this happened, as you can see here. Okay.
Okay, and so the next question, you are asking the audience whether you would use MCS? I think at Ichilov they would put an ECMO. ECMO is primed at Ichilov.
So in our center we don't have ECMO, unfortunately. The only option that we have is Impella. And we thought that it will take time for us to insert Impella and continue to treat the patient. And we decided not to insert an Impella at this point.
Okay, go forward.
So after having two wires, one in LED and one in circumflex, what do you think will be the next step?
Okay, we'll let the people vote for a few seconds. Classic dilemma: stent deployment, IVL, IVI, thrombus aspiration, balloon dilatation. I want to vote other because I don't know what it means.
I have a question. What is the hemodynamic status of the patient?
Yeah, 80/50, and she's having chest. She or he having chest pain.
Ischemic. Okay.
Yeah. Haitam, do you see the results?
No, I can't see the results.
So 14, the majority is voting for balloon DIL. 5 people voted for thrombus aspiration, 7 for stent deployment. So you have most people would balloon dilate the lesions, and stent deployment basically stays the same. There's, as Professor Perl mentioned, there's a bias because you see all the bars are coming up. So people are voting and changing their mind. I'm just saying, stick with your original plan. But other people are just re-voting. No, we're good. So balloon dilatation takes the lead, okay?
So,
I must say that I would aspirate.
So you can see here again the loop, and then we dilate the balloon in left circumflex. We inserted third wire, okay, to OM, to Ramos or OM, and it was simple to go with wire into the OM. And this was the result after balloon dilatation. And what do you think happened now to the LED?
There is a thrombus shift to the LED.
And
When you pulled the balloon with the thrombus, it went to the LED, of course. This is why I think you have to aspirate and to fully deflate the balloon before you pull the thrombus to the LED. You are near the bifurcation. And it started with catheter thrombosis. This was typical.
If you see this,
yeah, I would say this is
coming back to this, okay, with the story that the catheter was deep in left circumflex. I think people still think as a first diagnosis that there is a dissection here. But after it was easy to cross with the wires. And after balloon inflation, it became more
Evident.
more easy to say that it's maybe a thrombus and not a dissection. Yeah.
I think
So at
there
this
are
level, we took the
few-
wire from the Ramos and go with aspiration device to the LED, aspirate, and nothing changed in the LED, and then balloon dilatation in LED.
and the thrombus travels to circumflex. Now we have a ping pong.
And that was the result after balloon dilatation in LED, circ and Ramos, okay? What's next? What to do now, okay? We have 3 wires. Balloon dilatation was performed in LED, Ramos, and left circumflex.
The LED is already stented, right?
No, the LED had this, the stent from the previous catheterization, but there is no stent here. And I can tell you that we used a cutting balloon after a non-compliant balloon. Cutting balloon because there was an ISR and a stenotic lesion proximal to the ISR.
What I would say that at this stage I would leave the patient like that, bring him to CCU on IV heparin, maybe integralin, and bring him to a second look in 24, 48 hours.
Maybe ideas from our audience? Who would leave it? Who would stent it? So you would put a stent from...
Stent.
So Professor
Thank you.
Barabash Haitam says quietly and very non-aggressively that after a pre-dil with a cutting balloon, he would not leave this patient. He feels unsafe, but he would opt for stenting at least the LED part that was inflated with the cutting balloon. Other ideas?
DCB.
I think it's a good strategy to support Barabash. Generally say.
So basically all the options are on the table except from MCS and ECMO. So do you want to show us what you did?
Yeah. So...
oh God, imaging, no.
And so we perform IVUS in order to see what happened to the LED, Ramos, and the circumflex. This is from left ear. This IVUS from left ear. As you can see, we couldn't see any dissection, and also no thrombus was seen. But balloon dilatation, I think, balloon dilatation can treat both diagnoses. I think also dissection. And more in case of thrombus, it will be more effective. So you can see here that there is no thrombus and no dissection. I was to the LED, as I've said before, showed an ISR and a stenosis proximal to the stent. That's why we use the cutting balloon. And there is an IVUS from the left circumflex. You can see the left circ, the LED, and the Ramos without dissection in the origin of the two vessels.
Surely it was the imaging before the procedure, right? It was the imaging before or
post
after?
ballooning.
Everything is after, okay.
Yeah, post ballooning. And then we decided to go with DCB inflation in left circumflex, DCB to the Ramos, and then stent implantation from left main to LED in overlap with the previous one.
So you must defend this. So I know that you've just changed it because Barabash said you need to put a stent. But just explain me, if there was no dissection...
You wanted to put a stent just in the LED, right?
No, but he had really weird ideas, I know him. Just explain the rationale of stenting the LAD and DCBing the rest of the vessels. So what was the impression that you had to perform DCB just because you had a dilatation of a balloon?
First of all, I have a dilatation of cutting balloon in LAD. The original stenosis was in LAD, yeah? It was stenotic with the ISR, with the stenosis proximal to the stent also. And we have predilate with the cutting balloon from left main to LAD, okay? So I thought that I need to go with the stent from left main to LAD. And because we don't have a stenosis previous to the procedure at the beginning in the circ and the Ramos, I decided to finish it with the DCB.
So basically, whenever you do a dilatation, a PTCA with balloons, you usually end up with DCBing these vessels, even if there was no stenosis, because these vessels had no stenosis, basically, right?
Yes.
And I have a colleague here called Ilya Litovchik. Would you stent the LAD so it kicked off with an ISR?
If you trust your IVOS, I don't trust this IVOS specifically. I would use the IVOS that allows to see the vessel. Actually, this was another type of IVOS. But if you trust the intravascular imaging and you can prove there is no dissection or it is in controlled dissection, secured in the distal edge, it won't propagate with the blood flow, and you have no a good luminal gain, it will be fair enough to use DCB also in the native artery in the LAD also. It's my opinion.
And maybe if we're talking about, maybe we should elaborate on the different type of intravascular imaging, because this is a 25-ish megahertz versus 40, and remember that nowadays we have OCT. So especially if we're looking for answers related to the lumen, whether this was a thrombus, whether you want to see a dissection, I think that OCT would be more appropriate. Again, I think it is really wise that intravascular imaging was done, and it definitely saves the case, but as Ilya mentioned, if it's possible, do or use a device that you can actually see and interpret and make your cognizant decision based on these images.
So I think, as all you know, I have moved from one center to other center.
And you haven't
and,
took...
and I have only the Volcano.
No, you're good. No worries about
now
Volcano.
I have Volcano, Refinity, and Ibis Polaris in the on-shelf. So.
I would like to stress something else about ballooning many times vessels after recanalization of a thrombus embolization, that any balloon inflation risks no reflow phenomenon. So if considering the pathogenesis of the occlusion of the circumflex and the ramus, I think the result is very good, and I congratulate you for this, but we have to consider that there is something to lose when you inflate DCB or other balloons after such an incidence of embolization.
Item, a question. So in retrospect now, what do you think was the origin of the thrombus in the circumflex? Was it from the catheter or coming from the LAD backwards? What do you think?
I think that a wire replacement from 6 French sheet to 7 French sheet, we didn't flush the sheet, the previous one and the new one, okay? Because we have ACT of 340, it's less possible that it's from a catheter, yeah? I think it's from the sheath, and we bring it with the catheter into the coronary artery.
No, I just want to add one consideration, and that is in cases of flow-limiting dissection, and these are things that we all know, I just want to remind that you might not want to use OCT, right, because of the need for injection of a large quantity of contrast. And so if you have IVOS in that case, and the trade-off is the quality of the imaging, of course, sometimes.
So
but if you have an IVOS that you trust, use an IVOS.
You would use the IVOS, but post, once flow is regained, I think that if you want to see let's say make your decision based on whether you see dissections or thrombi, OCT would be much better.
Absolutely,
but
you get a better.
No one will pull two
better
catheters,
understanding
right?
of the mechanism with the OCT for sure.
Yeah, that's also true. Okay. Haitam, I think, are you done, or you want to show us your conclusions and summarize the case for us?
I'm about to finish. So
Brilliant.
this is the case. This is the after stent implantation from left circ into from left main into LED, and here's the IVUS from LED to left main after stent deployment, as you can see here. And this was the final result. After performing IVUS, I have 3 wires in. Okay, so I thought I should take the 3 wires with the catheter in order to avoid catheter deep engagement again and stent deformation. And then I came back with the diagnostic catheter, as you can see here, and make a final angiography in order to see that everything is okay. And I think I want to summarize it's sometimes difficult to differentiate between dissection and thrombosis, and it will be more difficult after balloon inflation that can treat any of both diagnoses. Intravascular imaging in this case was important to us in order to verify that the dissection maybe does not exist or was treated. Intravascular imaging allows us to treat suspected dissection with DCB only. And then when you engage your catheter with caution, and I think the most important thing that I want to say that we need to flush radial sheath after we replace the radial sheath, yeah, because at the end I think that everybody of us started to think that it was dissection and finished with thinking that it was the thrombosis.
Great.
Thank you. Congrats.
Thank you so much for this. Congrats. I have one last educational comment. I think that the most important step that you took was not to stent it, because let's just all think about this case. You have a patient on the table with thrombus or something gray in the left main. You just throw your wires in and you want to stabilize the patient, and sometimes we go and just stent it. And I feel that this is a bad instinct, especially for the young and less experienced operators. The quieter you have, the quieter situation that you have is the best. So if you regain flow, I'll call the next one. If you regain flow with balloons, you're not committed to stenting, I think that's the wise thing to do. First thing you want to do is just preserve flow. So if you have a thrombus or dissection, whatever it is, just inflate a balloon. Don't go for stenting, because stenting you're now committed and the disease is done. So I think that if I were to take some learning point from this beautiful case, was to stop, think, regain flow, and then rethink your next steps. So this was a really nice case, and thank you again for presenting. Thank you, Haitam.
Thank you. Thank you.
So it's a pleasure to introduce Laura Novelli from Milano. Star to the rescue. Can you hear us?
Good morning. Can you hear me?
Hi, Ken. Yes,
Hi,
we can
thank
see
you very
and
much
hear
for
you
the
well.
invitation. So wait a second, I will share my screen. Can you see it? Can you see my screen?
In a second. Yes, now we can see it.
Okay.
It's
Okay,
a
the
sunny
slides
day
are
in Milano.
moving. Okay. So thank you very much for the invitation. It's a pleasure for me to present this case. It's an 82-year-old female with typical cardiovascular risk factors such as arterial hypertension, dyslipidemia, diabetes. She was also an active smoker. As a prior clinical history, she underwent SAVR plus CABG using 3 vein grafts, one on diagonal, one on the LAD, and one on an RCA. Subsequent coronary angiography showed actually that the venous graft for the diagonal and for the RCA were occluded. And talking about medication, she was actually on optimal medical therapy for anti-angina medication, but despite that, she was keep having exceptional angina with a CCS3. The echo showed a normal ejection fraction with no regional wall motion abnormalities, and the ECG showed like a left bundle branch block. She had also a normal renal function. So this was the basal angio. As you can see, there was a nicely patent venous graft to the LAD. And talking about the native left system, the circumference was quite good with not significant stenosis, at least related to her symptoms. And this is the right system. As you can see, we have a negative remodeled RCA, diffusely diseased with a lot of calcium and stenosis. So, of course, the patient was not eligible for a redo CABG, so we decided to undergo for PCI. So the trouble starts at the very beginning because we're unable to deliver a workload guide wire to the distal PDA. So we decided to switch to a polymeric guide wire, the Sion Black, that finally reached the distal part of the RCA. But after that, we were unable to cross the lesion with any balloon. The low profile balloon didn't cross and didn't expand as well. We tried to advance the support as all the algorithm for uncrossable lesion said with a guide extension. And also, as a last bailout, we even tried the turnpike gold. There is a coiled torqueable big profile plaque modified microcatheter that had the idea to screw inside the plaque and try to modify it. But of course, it fails again. So we were facing a balloon and microcatheter uncrossable lesion. So now what to do?
Ready to vote, right? So Laura, do you want me to deliver the votes for you?
Yeah, of course.
All right, so 9 people thus far opted for changing to a more supportive guide cath. 2 people for anchoring, and 11 are now pro rotational athero. No one for granuloplasty. I'm not sure everybody knows what a granuloplasty is. But I do, because I have Litovchik by my side. So basically you have a tie between changing to a more supportive cath and opting for rotational atherectomy. Do you want to take it from here?
Yeah, of course.
Brilliant.
Of course, all the options were good. Of course, as all the algorithms said, in this case, you should first of all try to enhance the support, but then, of course, you have to do something like modifying the plaque. That could be with using rotational atherectomy or the granuloplasty that is just exploding a small profile balloon inside the plaque in order to modify and soften a little bit the plaque. But we decided to go with rota. But as expected, we didn't have a micro to change the wire. And so we went with a direct wire with the rota wire, but of course, wasn't an easy wiring, and so we failed to reach the distal PDA, and the guide wire kept tracking the acute marginal branch. And so now again, what to do?
Laura,
the suboptimal
can I ask you a question?
position.
The problem was crossing with a balloon and a microcatheter. This was your problem. So you could not change for a rota wire?
Exactly.
Okay.
So the idea, we had to do a direct wire with a rota wire, but of course wasn't an easy wiring. So of course we failed to reach the distal PDA, and the wire kept tracking this small acute marginal branch. So we had this wire, the rota wire inside the marginal branch, and so we had to decide to accept this suboptimal wire position just to rotate at least the uncrossable lesion on the mid portion, and then try to do something else, or we should try another strategy before doing rota in a suboptimal position with the wire.
Before answering the rota, can you tell us what low-profile balloon did you use to try to cross?
A relay balloon that it's a really good crossing, with a really good crossing profile, 1.25 at the very beginning.
So
but
the
it
audience,
failed.
please answer the question. Should we accept its optimal wire position before rotablation? Oh, it's not a question? Okay.
No, there was only one question to vote, so Laura, you
Okay.
can continue, sorry.
Okay, so we did accept the suboptimal wire position, and we did the rotational atherectomy using a 1.5 millimeter bar.
Before you continue, can you tell us what are the potential risks of using a suboptimal wire position?
Yeah, of course, if you are going to distal in the lesion, of course, you can track the marginal branch. That, of course, was a really small branch. Even in a big RCA, of course, the risk is to go too forward with the rota. And so the risk of having a perforation at the level of the bifurcation, it's pretty high.
There is another risk of losing the wire and the wire starts to
Yeah, of
rotate in
course.
the aorta. This is more dangerous.
Yeah, of course. Yeah, but the wire actually was quite distal in the marginal, so we didn't really care about losing the wire, but more about the carina where the bifurcation starts, and so the risk was having a perforation at that level because, of course, the marginal branch was not that big to accommodate a 1.5 burr. So, of course, we did it, and this is the result. We have a big perforation at the level of the mid-RCA, and of course, to make things even worse, the patient moved and we lost all the guide position, and there was also a sudden hemodynamic deterioration. So after that, as we know, so at this point, what to do, in your opinion? With a huge main vessel perforation, with not anymore a wire down in the vessel, and of course with all the difficulties that we had to deliver a guide wire in the distal part of the RCA.
So we don't have that online because we did not upload that. So let's just try and vote and see here.
Well, I don't know if you want to discuss it.
Yeah, okay.
Could be interesting.
Coiling, condom technique, again, I'm not sure who's
First of all,
responsible for the choosing of words. Dissection technique or vessel plug?
First, we have a perforation, right? So we have first, and the vessel is not that big. I mean, I think the most important thing is to avoid tamponade at this stage and to first occlude the vessel, try to control the bleeding.
what's the first step?
Balloon inflation.
Sorry.
No, we're all saying the same thing. First of all, put a balloon there and stop the bleeding. Right? And then your choice of perforation sealing depends on your preference, I think. Right?
Do you already have wire in place at this stage?
No. We lost
no.
everything.
No.
It was an horrible case.
No, what a shame.
So, of course, the coiling could have been an option, but of course it was a main vessel perforation, so of course we had to use a lot of them and big one. The condom technique is like using a balloon just to, with a stent inside, creating like a condom and seal the perforation. But of course it's like, it takes time to create this type of device. So we decided to try at least with a dissection technique, because our idea was, in the best case scenario, creating a knuckle and tracking the RCA would have been useful to close the perforation, but also to recanalize the artery. So it was a win-win. But of course, as you said, the first thing during perforation is to inflate a balloon to stop the bleeding. But also in this case in particular, we use also the balloon to provide the support for the micro to create this knuckle. We use a Fielder XDR that, it's a soft tip load polymeric jacketed wire. And so, of course, the knuckle tracked the marginal branch, but was good enough, because after that, we advanced an extension and deliver a small amount of contrast to identify the perforation site. We dilate the channel that we create inside the subintimal space, and then we seal the perforation and the subintimal space with 2 cover stents. And this is the final result. Of course, it's not the best that we could have gained, but of course the patient was alive. So We rapidly controlled the bleeding. The patient didn't experience any tamponade and we didn't need to do pericardial drainage. The patient also was then stabilized in the CCU and then was discharged in day 13. And of course, she had an inferior MI, and the equal discharge showed a mildly reduced ejection fraction, akinesia of the mid inferior wall, and a reduced right ventricular function. But at least the patient was alive and went back home. So thank you very much.
Thank you.
So for those of you who are not acquainted with all the acronyms of CTO, so STAR is subintimal tracking and reentry. So that was, I think that the main message was how to utilize CTO operators and CTO techniques in a non-CTO case. So that was the case. But I think that Professor Segev had some...
I think, can you show us again the injection of the SVG to the LAD?
Yeah. Wait a second.
So, you know, in retrospect here, and I think this is what would be my first decision in an 82-year-old with stable angina, right? This RCA should not be treated at all. This is something that should be treated conservatively, and if something is to put a stent in the LAD lesion here. This is the only thing I would do in this patient.
Okay. Yeah, I think it's a nice comment.
That was my time. So we're still maybe some few comments from the audience, but yeah.
Yeah. First of all, there is a very problematic artery to approach for the beginning, and the clinic state of the patient is the more important thing. Mm-hmm. And the other way, when you see a staining, you have to decide is the myocardium or is pericardium. It's myocardium, you have to wait and to see the develop. So when in this case, it's not in a tamponada, we think conservatively from the beginning.
Yep.
I think this is a lesson that we learned. You don't leave perforations after rotablation for conservative treatment. You have to solve it in the cath lab. You don't send the patient to the ICCU to see whether he deteriorates or not. And also there was a clinical presentation of this patient after she was very symptomatic after the perforation, after the incident.
Yeah.
So you don't leave these patients, you have to resolve this in the cath lab, you don't send these patients anywhere. And I would like to strengthen your things. Those tools of CTO performers are extremely important for such cases. These techniques are life-saving.
I have to add one comment. Even a small amount of blood in the pericardium after CABG may be a disaster because of a localized tamponade or dry tamponade that may occur in the post-CABG patient.
Maybe explain what a dry tamponade is.
Dry tamponade because of adhesions in the pericardium after the pericardiotomy. They might be some pockets or some pockets, yes, that will fill up quickly with a small amount of blood and create a significant hemodynamic impact on the heart function because they're localized and the pressure will rise up very quickly. So even a small hemorrhage may be disastrous in this case. And I think that well, I have to say it's a wonderful case of tackling the non-CTO case by CTO technique is my beloved topic, very nice, good STAR, and so on. But from the beginning, and I'm taking it one step ahead of Professor Segev, well, the decision to treat the RCA, but you're with suboptimal wire in rotor wire. Which wire is it? It is a floppy wire, and this is suboptimal with the acute angle. You can just tear the wire with the rotor bear in the very significantly calcified lesion because of the acute angle into the marginal. And if it's a supportive wire, you can just floss the bifurcation. So either way is dangerous. I would not do rotablator if I have no wire in the proper position.
So I think, Laura, these were really important comments. And again, for the sake of being an educational course, as we said with the Hitem's case, the first thing to do is to stabilize the patient. I mean, you can think about all the techniques and whether you have coils or whether you have plugs. And sometimes, at least in some of the centers, some of the equipment is not readily available in the lab. But the first thing to do is to reassess the patient, call the CCU, make sure that you have your hemodynamic support system and the ability to do a tap if needed, and put a wire in a balloon. So this is the first thing you do. Then you buy time to think, because if you work on instincts and you stop and you hold and you say, okay, the patient's now stabilized, the bleeding just stopped. Now we can start share our thoughts. Maybe call a CTO operator, make sure that we have everything ready, and then decide what to do. So if I were to take again one important lesson, is beyond the fact that you rescue the patient promptly and really well, is to stabilize the patient first, buy some time, think, call the rest of the gang, call the rest of the team, and make sure you have all the proper gear in place. Other comments, guys?
I have 2 points. Maybe I can share.
Yep.
One point, if the wire of Rota was a Rota drive wire, because it's more easy to manipulate with the Rota drive wire.
Mm-hmm.
And
Yeah,
the
it
second
was.
one, Rota drive. Okay. And the second one, if you thought to go with the orbital atherectomy rather than the rotational atherectomy, and the wire of orbital atherectomy is more easy to manipulate, the Viper wire.
Okay. It's also
Yeah, of course, but actually we had so much problem with the normal workout guides where I know that these guides were really good. There's a super good tracking and torque response and whatever, but of course I don't expect that the Viper wire as well could have reached the distal PDA. And regarding, for example, doing the orbital atherectomy in this case with the wire inside the marginal branch, of course, I don't think it was a good idea just because the nose cone of the orbital has 6 millimeter length. So of course it's even more dangerous.
Laura, can you just final comment about the management of heparin and anticoagulation once such perforation occurs?
Yeah, of course. And I think, thank you for the question, because I think it's really important, because as we said, we don't have to get nervous or go for instinct. And of course, we do not have to reverse the heparin. We should go with normal heparin that we use. For example, in my center, we use like a SCT more than 2050, normally for normal PCI. And so I think it's really important not to deliver protamine, because the risk is to having a thrombotic complication instead of an hemorrhagic complication. It's better to say both of them in the same time. That I think it's the worst nightmare that every interventional cardiology has to tackle.
Thank you very much. This is a very common instinct that should be avoided with experience.
Yeah, 100%.
Thank you so much for presenting, and thank you all for participating.
Thank you very much.
Thank you.
Nice
So we're going
meeting.
to take a break, and then we'll regain for the second session. Thank you so much.
Thank you very much.
Joining us again at 10:40.